Hi, this is Michael Altos, and we're continuing our discussion of the GI system and antihistamines, and this is part 2. We've spoken about the H1 blockers, the H1 antagonists, and now we're moving on to the H2 antagonists. Since we said that the H2 receptor is really our GI receptor, it's not surprising that H2 blockers are used in the treatment of GI problems like GI ulceration, gastroesophageal reflux disease, and sometimes as a pre-anesthetic medication. Since stimulation of the H2 receptor causes hydrogen ion secretion, H2 antagonists inhibit gastric hydrogen ion secretion. They may also decrease gastric volume. Their duration of action is 6 to 10 hours, and if they are abruptly stopped, there may be rebound hypersecretion of gastric acid. Side effects of H2 blockers include diarrhea, fatigue, and headache, and rarely cardiac dysrhythmias or mental status changes. We should be aware that changing the gastric pH could change the absorption of oral medications, and chronic use may have some linkage to increased susceptibility to systemic infection. One of the early H2 antagonists was cimetidine or Tagamet, but unfortunately there were numerous drug interactions with this medication. This is probably due to the drug binding to many isozymes of cytochrome P450. And so we saw increased plasma levels of warfarin, theophylline, phenytoin, meperidine, nifedipine, and lidocaine, as well as increased estrogen levels. Nowadays, you are more likely to be using ranitidine or famotidine. Those are Zantac and Pepcid. They really have very few unique side effects or drug interactions, with limited or absent binding to cytochrome P450. Ranitidine is usually dosed at 50 milligrams, while famotidine is given at 20 milligrams. The half-life is just a few hours for the drug, but the clinical half-life is about 12 hours. Now that we're on the topic of the GI system, we're going to continue talking about other drugs that work on the GI system. The next class are the proton pump inhibitors, PPIs. These drugs inhibit the pump that transfers protons across the gastric parietal cell membrane and leads to secretion of gastric acid. PPIs also seem to decrease gastric fluid volume, although it's not really clear how significant this effect really is. There are many different PPIs out there, including omeprazole, which is Prilosec. Now this drug takes about 2 to 6 hours to start working, but lasts for at least 24 hours. Then there's esomeprazole, which is Nexium, which is just an isomer of omeprazole. Lansoprazole, which is Prevacid, which is a similar action. And then pantoprazole, or Protonix. This is potent and a little bit faster acting, and it's also available IV. So you may see people on a Protonix infusion in the hospital. There's a study that shows that 40 milligrams of IV pantoprazole together with 50 milligrams of IV ranitidine can increase gastric pH within 1 hour. The next group of antacid drugs we're going to discuss are the antacids. When people talk about an antacid, they're usually referring to a salt of magnesium, aluminum, or calcium. They neutralize gastric acid content, but have no effect on gastric volume. Now you've seen these medications, and they're all sort of white and chalky, and so they may be considered a violation of the NPO guidelines. These would be called particulate antacid because they are made of particles. There are many different kinds, including sodium bicarbonate, which is Alka-Seltzer, magnesium hydroxide, which is milk of magnesia, aluminum hydroxide, which is Mylanta, and then some mixtures like Rolaids and Maalox. In each one, you want to consider whether you want that specific ion, including sodium, magnesium, and so on, increased in this patient's body. And especially patients with renal failure should be considered very carefully before administering these salts. Another antacid is sodium citrate mixed with citric acid. It's called Bicitra. And this is the non-particulate antacid. It's a clear liquid, and we see it used a lot in full stomach situations, especially in OB. It does have an unpleasant flavor. I've heard people describe it as the sweetest and the sourest thing you've ever tasted at the same time. But there are some studies that demonstrate lower mortality from acid pneumonitis when patients who aspirate their gastric contents have been given Bicitra. That's because the pH is increased. Now that's true even though, in general, if you want to improve outcomes and lower mortality, you want gastric volume to be smaller. And here we're giving 30 cc's of this liquid to the patient. Nevertheless, when we give patients non-particulate antacids, there's a decreased likelihood of a foreign body reaction, faster onset of action, and these drugs are commonly used in full stomach situations. Take a moment in case you have any questions you'd like to jot down. Please drop me an email or discuss them in class. The next drug we're going to discuss is metoclopramide, also called Reglan. This drug binds to or sensitizes cholinergic receptors, specifically muscarinic receptors, in the GI system. It increases lower esophageal sphincter tone and doesn't seem to have any real effect on gastric acid pH. The main use for metoclopramide is to stimulate upper GI motility, to clear out the contents of the stomach. This has been used in patients who have full stomachs, including traumas, obese patients, pregnant patients, and patients with GERD. If patients have been given opioids, this can decrease gastric motility, and Reglan does not reliably reverse this opioid-induced gastric dysmotility. Reglan is also used to treat patients who have diabetic gastroparesis. Usually it's given 10 to 20 milligrams IV over 3 minutes, about 15 to 30 minutes before induction of anesthesia. If you give it too rapidly, it can lead to abdominal cramping. The effects of metoclopramide may be offset by the use of atropine. Metoclopramide is also a dopamine antagonist. Now, this isn't its primary mechanism of action, but it may partially explain why Reglan has an antiemetic effect. It's no longer used as a first-line agent for postoperative nausea and vomiting. Because of its dopamine antagonist properties, metoclopramide can produce dystonic extrapyramidal symptoms or akathisia, especially with long-term use, and it may worsen the symptoms of Parkinson's disease. Other side effects that are common include hypotension and, less commonly, dysrhythmias. Rare side effects include dysphoria and sedation. And some say to avoid metoclopramide in patients who have seizures, who are taking monoamine oxidase inhibitors and TCAs. Some studies show that metoclopramide can inhibit plasma cholinesterase activity, which would affect metabolism of succinylcholine and ester local anesthetics. Erythromycin is an antibiotic, which we'll discuss in the next round of lectures, but it also increases lower esophageal sphincter tone and promotes GI motility, and it has been used to treat diabetic gastroparesis and to increase gastric emptying. As always, please let me know if you have questions, and we'll finish this topic in the next recording.